Okay, I'll start with introductions then. As I said, I am Emma Wilson. I am the Communications and Engagement Officer for Research and Innovation at GMMH. We're really delighted to be starting a Research into Practice webinar series this year, and even more so that kicking it off is the Greater Manchester Dementia Research Unit led by Ross Dunne. So thank you all very much for spending your lunchtime coming to listen to us. So today we have two fabulous colleagues with us. We have Dr. Ross Dunne, who is the Director of the Research Unit, the GMDRC, Greater Manchester Dementia Research Centre, and he is also a later life psychiatrist at the Trust. And we have Lewis Harpin, who is a research nurse in our department and delivers an awful lot of the research that's going on in the GMDRC. So without further ado, I will hand over to Ross.
Thanks very much, Emma, and thanks everybody for turning up at your lunchtime. Hopefully you're able to eat and listen at the same time. So Ross is my name. I've been working in the Trust for the past 9.5 years, and I've been in England for the last 12 years since completing core training in psychiatry and some research training in Dublin. I was an academic clinical fellow in Cambridge for 3 long years, and then moved to Manchester because I missed the urban decay and the weather and, you know, the usual. So I'm going to hand over to Lewis for part of the talk where we talk about the actual nursing experience of learning how to do a new procedure. But I thought it would be useful to talk about the history, where we've come from, and then talk a little bit about where we're going to and how we're getting there. So keep going, Emma. Thanks. We're going to talk a little bit about diagnosis and history. So this Auguste D is the lady who Dr. Alois Alzheimer was looking after in 1907. And she passed away after having a very young onset illness. She had a very unusual presentation of what was at the time beginning to be called a dementia. And she had hallucinations, visual and auditory. She had a pathological jealousy of her husband and was deeply paranoid about him. And over the course of some years, her condition progressed, and Dr. Alzheimer, because everybody was both a psychiatrist and a neurologist and a neuropathologist at that stage, 1907, he was the man who performed the post-mortem, looked down the microscope and found 2 characteristic findings. So these were plaques and tangles. And over the course of the last 100 years, we've kind of figured out what plaques and tangles are. And we no longer need to wait until people have passed away from their illness to identify those proteins involved in plaques and tangles. It's worth focusing your mind a little bit on the picture on the left. This is a normal aged brain on the left versus somebody living with Alzheimer's. So we're talking about, and Alzheimer's Research UK talk about losing the amount of tissue that's in a large orange over the course of living with Alzheimer's over the 7 to 10 years. And that's something to bear in mind. We're talking about really serious amounts of cell death. Next slide, please. So what we have, the timeline developing over the last 100 years, maybe 120 years, which suggests that we have a large gap between 1907 and 1984, where we really don't do much work, don't find out much. At this stage, it's really a clinico-pathological entity. So people are looking down microscopes at brains once people have died. And usually that's in the context of research, and it has no impact whatsoever on treatment. Next slide, please. As we move on, we start to get some guidance about how you diagnose this disease a bit more specifically in life. And this is divided into probable and possible, depending on how many core features of the disease you have. And we start to realize that not all dementia is Alzheimer's disease. And in fact, dementia becomes this umbrella term and then becomes a name for a stage of disease rather than a type of disease. And it starts to become obvious through the 1980s and 1990s that we have Lewy body disease, we have cerebrovascular disease of the blood vessels, and we have Alzheimer's disease. And they're very, 3 big diseases that all lead to dementia eventually. Next slide, please. As we move on, we start to do big studies, and we start to study people in America and China. And what we do is recruit people in their 50s and 60s, and they volunteer to give us samples of their cerebrospinal fluid. It's this clear fluid that bathes the brain and spinal cord. And from that, we're able to look at the two proteins that we've discovered make up the plaques and tangles. The plaques are made of a protein which you can think of as like a sticky egg white, which is called amyloid. And inside the cells, we have a structure protein, a scaffolding protein called tau, and that makes up the tangles. So we've got amyloid and tau. Amyloid tends to come first in the illness and then tau. And we're able to identify those in healthy people who are going to develop illness. We can only do this initially at large scale, so you need hundreds and hundreds of people in your study. But as we go on, we find that actually these are probably illnesses, particularly Alzheimer's, but maybe the others too, that have long tails. So in other words, these are quiet, building up over a decade or more. Sometimes we've got good evidence that it's about 15 to 18 years now. And they build up in midlife, and then the disease manifests when people have symptoms. But symptoms usually correspond to a kind of stage 3 neuropathologically. So when you look at the brain under a microscope, there's well-established collections of amyloid and tau by the time somebody starts to have symptoms. Next slide, please. So as we go on into sort of 2011, we start to realize that there really should be, and there are starting to be, good tests for whether you have amyloid before you have dementia. And these start to be rolled out in certain centers in the United States, initially scans, and later on CSF testing. And they're only really used at this stage, 2011 to 2013, in certain centers in the UK, University College London, which hosts the National Neurology Hospital. And they're usually used for people who have maybe got disease or maybe not, and nobody can really decide. And so they're referred to the National Neurology Hospital to try and figure it out. And obviously, or maybe not obviously, but because taking a sample of CSF involves a procedure, this is not trotted out across memory clinics in the UK. And that's because psychiatrists traditionally don't do the procedure. We don't have the facilities to do it. We don't have the facilities in our laboratories to analyze it. We don't own laboratories. So we'd have to agree with other trusts to do it. So what we're going to talk about next slide, please, is what the basic sort of science under this is. But in 2018, we have a new framework for understanding this disease. We're able to call it Alzheimer's before people have dementia. And in fact, last year we moved on further. So there's really detailed guidance now from the National Institute for Aging in the United States about how we should decide on the basis of these tests whether somebody has Alzheimer's or not. And that doesn't require a large degree of cognitive impairment. Okay. So we talked a little bit about the history of plaques and tangles. We talked a little bit about the development of the idea that you can have amyloid collection in the brain and then tau collection in the brain. And we've really dispelled this idea, I hope, that Alzheimer's is dementia, or that you only have Alzheimer's disease when you reach the stage where you have a real loss in your function. Actually, the disease takes 10 to 15 years to build up. And during that time, you may not be aware of it. And even if we measured your function on pen and paper tests, give you quite hard pen and paper tests, you still may not be aware. It may not show up. So detecting these things is quite important. Okay, next slide, please. So I mentioned amyloid and tau, just to help you visualize this a little bit. So we talked about, and maybe you want to outline the top there, A. We talked about a scaffolding protein, and this is really, it wasn't an extended analogy. That's exactly what it is, a scaffolding protein, which then comes off and binds to itself and starts to precipitate in the cell. That's tau. And we're still not completely sure how amyloid makes tau start to collect against itself. And certainly true that you can have a tauopathy, and particularly a familial disease, that isn't related to amyloid, and that will often present as frontotemporal disease, so frontotemporal dementia eventually. We know a lot about these two proteins now. We know how tau starts to stick together. We've studied that at a chemical level, and we know how you can potentially stop it. And some of the work that we do is on clinical trials of agents that might stop tau sticking together. And if you can stop tau sticking together, then you can halt the disease, because it is crucial to causing cell death further down the line. Okay. And again, just to get a good idea in your head of the kind of structural change we're talking about, if you look, I don't have a pointer, but maybe Emma can, if I describe it well, maybe Emma can outline it. So on these scans, which are coronal sections through the brain, in other words, as if we sliced you from front to back, what we can see is a kind of a stalk of a cauliflower. Can you see that, Emma? Which is now a little bit lower and to the left. So that's your temporal lobe. Cauliflower sticking out to the left and a cauliflower sticking out to the right. And inside the temporal lobe, you'll see something that looks a little bit like a Swiss roll, just closer to the center. And that Swiss roll is your hippocampus. So it might be clearer on the next slide. I've asked Emma to become a neuroradiologist without warning her. So these are the areas that we're looking at for cell damage and for cell death. But we know that only occurs at about stage 3. So we're really talking about later biological changes that are detectable on MRI scans. Most of the people that I see in my new clinic have normal MRI scans. So they have problems that have got them to the GP and they present it to me. I'm very happy to see them. They have normal scans, but at least 60 to 70% of people with those normal scans go on to have a diagnosis of Alzheimer's disease, which is not yet dementia. And when we're measuring functional impairment, of course, which is, establishing the stage of the disease in terms of how you're functioning, not only are we usually talking about later stages, but it's quite subjective. So you will know people who have never used a washing machine and never balanced the checkbook and never used an ATM. And this is more prevalent in some cohorts than others, but some spouses are very well looked after, let's just say that. So it can be quite difficult to detect functional impairment in some people. It depends, of course, on your education, your occupational attainment, your socioeconomic group, whether you're a member of a minoritized community. So if your working life consists of doing manual labor, coming home, having a couple of pints, watching the soap and going to bed, and that persists into retirement, there isn't a lot to detect there in terms of functional impairment. And those people will often present quite late. Whereas your leafy greeny Didsbury set, who are going to the University of the Third Age and trying to learn a language in their 60s and are challenging themselves on a daily basis, those people tend to become more aware of their cognitive impairment earlier on, and so they present earlier. Even if it's a matter of a doubling of their Times crossword time, so they will often present earlier. And for that reason, we're able to sort of answer that question a little bit earlier. I think one of the challenges we have is to try and push back through the disease so that people do notice it earlier. And if they have a concern, they seek help. We use a scale to measure how impaired people are on a day-to-day basis. And we do this mostly for research, but it has a clinical use as well. In fact, it was designed for clinical use. So you can look up this. And I'm happy to provide the link. It's called the Clinical Dementia Rating Scale. It's usually a 40-minute interview, but you can also use this grid to sort of just place people in terms of how impaired they are. People with an overall score at the top there of 0 or 0.5 are in what we would call the mild cognitive impairment range. And then 1 is probably mild dementia or early dementia. And at 2 and 3, dementia is obviously noticeable. Okay, next slide, please. So if we were to describe somebody in the round who's living with one of these diseases, and particularly Alzheimer's disease, you describe their biological status, whether they have amyloid or tau or both, or neurodegeneration as measured by one of the proteins in the CSF or as measured on the scan. You talk about their cognitive functioning in terms of some scale, name the scale and give the score. You talk about their functional status, whether it's CDR 0, 0.5, 1, 2, or 3. And as we always have done, we talk about the risk in terms of living at home, safety with doors, safety with fire, safety with ovens, safety with gas, safety with cigarettes, all those kinds of things. And the care needs follow that functional impairment often. So a lot of the people I see in clinic don't have care needs, don't have carers, and don't want to be described that way. And in fact, they have, sometimes rip-roaring Alzheimer's disease, but they're still doing everything for themselves. and they know that they, have 5 years, maybe 6 years before they're going to develop serious functional impairment, and they're able to use that time. Next slide, please. Okay, so we have some older drugs, which I'll mention because I'm going to come on to the newer ones. We have drugs like the acetylcholinesterases and memantine. They're only licensed in the UK for the treatment of dementia stage disease. And it's pretty good evidence they're not that effective. So if you take 1,000 people on donepezil, for example, and 1,000 people not on it, the average difference is about 1 point on a 30-point scale, the mini mental state examination. So that's a pretty meager effect. Probably only lasts for about 3 months. Looking at some of the population studies, and it's probably a little bit more effective in Lewy body disease, actually. So prescription's really based on the degree of functional impairment, whether people want to take another medication, what benefit they think they're going to get, and some people just don't want it. And certainly the people I see in clinic now, the earlier people, it's not licensed for them. They're probably going to get more side effects than benefits. And really, if they do get side effects, that might put them off taking it when they're further down the line. So I don't terribly encourage it. Some people will insist, and about 50% of them regret it, probably. Next slide, please. Yeah, so we do have a set of new medications, and you may have seen these in the newspaper or in the media. Lecanemab and donanemab. And these are drugs that we've trialed over many years, including some trials in Manchester here. And they are licensed now, but not available through the NHS because of a cost effectiveness analysis by NICE. And essentially, the nitty gritty of this is that they were trialed over 18 months, which is, a good duration to detect some cognitive decline if you've got 3,000 people in your clinical trial, but not a very good duration to demonstrate to a state that they should pay for it because it prevents further decline. So the drug companies, not that I'm very sympathetic to them, but we're kind of trapped because you can't keep recruiting people if you know something works. You can't keep randomizing people to a placebo group if you know that the drug works. That's just unethical. But at the same time, we'd like to develop some evidence of what the long-term impact of these drugs are. But if nobody will let us have them, it's very difficult to develop that evidence. So we're working on that at the moment, and we're chipping away at the MHRA and other people to let us do some phase 4 studies and maybe be one of the pilot sites for the availability of those drugs. They're very serious drugs. They have serious side effects. And we'll talk a little bit about some of the preparations we're making to be ready to give them. Next slide, please. So Brain Health Manchester is a clinic that I set up about 3 years ago now. And what we do is we take the people who are referred by GPs to the memory clinics in North, Central and South Manchester, and we triage them. So we look to see whether they're cognitively impaired and whether they're functionally impaired. And if they're functionally impaired, in other words, they're a bit risky, they're getting lost, walking outside, they're probably not for us. Those people probably need a traditional memory assessment service with access to the old-fashioned drugs, with social support and all those kinds of things. But the reasoning behind it is that the people who come with milder forms of impairment, who don't have functional impairment, that can be more difficult to detect. And it can be much more difficult to decide whether there is, in fact, an underlying disease. And they need a bit more work. So everybody through the clinic gets a scan, gets an MRI scan, which wouldn't be necessarily true of everybody through the MAT service, particularly somebody who's living in a nursing home, who's multi-morbid, maybe in their late 80s. Everybody gets a serious cognitive test called the ORBANS, which measures them against people their own age. So not just how much did you score out of 100, but how do you score compared to other people aged 85 or 75 or 65? And this is a much more therapeutic conversation with people in terms of how they measure up. And of course, we factor in occupational attainment and educational attainment as well. So establishing this clinic, we had been talking about it for about 4 or 5 years. And then finally, we got access to a little bit of Health Innovation Manchester funding, roll out the CSF testing, and I went off trained in lumbar punctures in Salford Royal and hung around there in the neurosurgery unit and did about 10 or 15 LPs to try establish for the first time, I think, in UK Mental Health Trust, the ability for patients to access these tests. Next slide, please, if you can hear me. Right. So when we're making the diagnosis, we're using this sort of mental model that in time CSF A beta 42 can build up in your can change in your CSF, and that comes first, and then we have changes in tau a little bit for and then as time progresses, start to see mild cognitive impairment and then dementia stage disease. Next. The background to this is not just like this. We have from 2016, 2020, and now the latest in 2024 from the Lancet Commission on Dementia, we know that the significant lifestyle factors and environmental risk factors are viable if you catch people early enough. Now, the evidence really there that you can necessarily change the trajectory once somebody has established Alzheimer's disease. But if they have the very earliest beginnings of it, things are on the borderline, and they're at risk of developing dementia, then there may well be a chance to intervene. And in fact, the next study shows some of that. Did we get rid of fingers? I'll talk about fingers. So fingers was a study done by Mia Kivi-Pelto in Finland. And what she did was essentially people were chased down the road by a physical trainer. They had very tight blood pressure control, and they had some cognitive stimulation therapy. These weren't people with dementia. Some of them may have had MCI, but most of them were just at risk. And there's pretty good evidence on the basis of 600 people per group that the progression of cognitive decline could be slowed down by non-pharmacological measures. So if we could do that at a population level, we'd have reduced the number of people living with dementia. And if we can do that, we can have a very significant impact on health and social care. So what we're doing at the moment as a sort of a national project is working back through the disease to see how early it is feasible to diagnose cognitive problems and how early it is feasible to intervene and what's acceptable to people in terms of interventions at this stage. So our ambitions in setting up the clinic are here. They're not groundbreaking. You might think that they should have been provided already. I certainly did. But one of the key features was we need to have a framework for diagnosing people early so that the new drugs can work. Next slide, please. So in a typical pathway, people are referred usually at the dementia stage. 30% of people are referred at the dementia stage. GP will sometimes do a test, sometimes not. Usually they're seen by a nurse practitioner first. These are often absolute experts and have been doing it for 20 or 30 years. They will use a test, which is more sensitive than what the GP does. If they're mild, usually they'll go on and have an MRI to develop a bit of clarity. But most centres in the UK are not, most MAT services in the UK are not commissioned to follow people up. Now, it's heartening that some of the commissioners have been listening to us and started to commission things like 1-year follow-ups, so we can see if people are kind of stable or not stable. But that doesn't happen everywhere. And in fact, in most places it doesn't exist. If they have more severe impairment, dementia stage disease, then they are given a diagnosis and they may be given some donepezil or memantine or something like that. And usually then they're followed up for 12 weeks. What's interesting about this diagnosis bit is it's wrong in 30% of cases. So what we know from studies done in the United States and elsewhere is that if I only have a scan and a pen and paper test to go on, and a clinical history, of course, and maybe a physical examination, I'm wrong 30% of the time. Now it's been interesting in talking about this publicly over the last 3 years, because there's quite a bit of resistance from the field to accept that they're wrong 30% of the time in terms of a subtype diagnosis. People sometimes take it very personally and get offended, and they believe that everybody else might be wrong 30% of the time, but not them. Thank you very much. But this is evidence from national centers in the United States. They're pretty good at diagnosing Alzheimer's disease, and they're still getting it wrong. And they get it wrong both ways. So people who don't have Alzheimer's are diagnosed as Alzheimer's, and people who do have Alzheimer's are missed. And I personally think that that's when we have technology that can make the difference and make the diagnosis, probably not acceptable. Of course, this has to make a difference. So if somebody, again, is nearing the last 2 years of their life in a nursing home, they're multi-morbid, the nurses have noticed that they have very severe memory impairment and day-to-day confusion, this is probably not a test for that person, because it's probably not going to be that useful to them. If they have very established dementia and they're nearing the end of their life, we are not intending to drag them into clinic and give them lumbar punctures, and nobody should be. Next slide, please. So what we're trying to do is get to a disease diagnosis using these technologies and get as many of those people into research as possible. Because if there is no treatment, then the gold standard treatment is research involvement. And what the pathway does is it makes sure that we're only putting people forward for clinical trials and studies who definitely have the disease and that can therefore benefit. And so we're not anymore taking a punt on whether they're in the 30% or not. We're now making sure that people are good candidates before they go forward. Everybody should have access to research. I think everybody should have access to a timely disease diagnosis. We're not going out and recruiting at Piccadilly Gardens to student people, but everybody who thinks access to either an all clear or a disease diagnosis. And what we do as well is we talk about hearing, we talk about blood pressure, we talk about alcohol intake, smoking, all the things that might be quite low-hanging fruit for behavior change that might reduce the risk of progression. So we do these screening, and these are well people, so they're able to answer questionnaires on things, their health behaviors, their diet, their hearing, their level of depression, anxiety, things like that. And they do that before they get to clinic, and we're able to go through that and look close at that in terms of what it's going to mean for the focus of the interaction. Next. Okay, so Lewis is going to talk to you for a couple of minutes, and we did start a little bit late, about his experience of initially being bullied into and then starting to enjoy learning a new procedure. Thanks, Lewis.
Yeah. Hi, everyone. I'm Lewis Harpin. I'm a research nurse. I've been doing a research nurse job for about 13 years. And as Ross has suggested, I did not expect to be training to do lumbar punctures at any point in my career. But here I am. I find myself doing it. It's a nice picture here, which shows a lovely image of a spine that makes it look like a very simple, straightforward procedure, which I think it can be with lots of training. It's a proper clinical procedure, so we scrub up, make sure it's completely sterile, and as you can see, we look for a nice space in the anatomy of the spine to put the needle in and get the fluid out. We use, obviously, anesthetic to numb the site initially, so there really should be pretty much a pain-free experience for the people who undergo the procedure. The worst you're going to feel is the smallest needle we can find, delivering that initial piece of anesthetic. That should then be the only pain you experience throughout the procedure, and we ask people to let us know how they're feeling as we go through. Should we do the next slide? I think this is the main practical thing that I experience anyway, is meeting the people who are having a lumbar puncture, how it's explained to them, and what their expectations are. I think most people, understandably, are rather nervous about submitting themselves to having a needle inserted into their spine. Seems understandable. And I think some of those misgivings come from things probably you guys have heard about as well, stories about lumbar punctures that have been unpleasant and difficult. And I think that it's because most lumbar punctures are done in an emergency situation in a medical hospital where you need to get things done straight away. So people don't give enough anesthetic, they don't take enough time, and it's usually done in a bit of a hurry. Obviously, that's not what we're doing in the clinic. We spend a long time speaking to the person and the relatives about what to expect, bring them through into the clinic. They sit down with their back to us, just take as much time as possible to make people feel comfortable, understand what they're going to experience. And this has resulted in far fewer side effects. I mean, the usual side effects from a lumbar puncture are post lumbar puncture headache or some back pain. And I think in clinical settings, it's usually sort of 20 to 30%. Ross can correct me if I'm wrong. But from our clinic, it's more like 4 or 5% getting a headache, maybe even less than that. So the feedback we get from people who are initially nervous is that actually this was much easier, more comfortable than I expected, and I would recommend other people to go ahead and have a lumbar puncture to find out the answer to that question. What is there something wrong with my memory? Next slide. So this is an important one, just to say we haven't just started doing lumbar punctures off our own back. Ross has spent a long time making sure that the setup is safe, accredited, that we have all the clinical governance you could possibly imagine in place, so that everything's done above board and on the book. Well over time already. If there's anything I've missed out, I'm sure Ross will talk about it now.
Maybe just a quick overview before we get questions on some of the research studies we have going at the moment. Emma, do you want to fast forward to that slide? Yeah, so maybe the 80 Smart and then our other projects. Is that okay? Excellent, thank you. So I wanted to talk to you a little bit about this innovative trial we're involved in. I'm a co-investigator on the study with Paresh Malhotra in Imperial College and colleagues around the country. It's been now funded to the tune of about £5 million over the next few years from the Medical Research Council's Clinical Trials Accelerator as part of the Dame Barbara Windsor Dementia mission. It's a platform trial, and you might have heard of these kinds of things, which are essentially sharing a placebo group. So normally we randomize a group of people, 1,000 people, say 500 to receive a drug and 500 not to receive the drug, but to receive a placebo, a sugar pill, or something that they can't tell whether it's the drug or not. They're blinded, I'm blinded, I don't know whether they're getting that or not. That results in quite a lot of waste. So actually, for every trial, you have to recruit another placebo group. And what we've done is mimicking some of the work that was done in the recovery trial during COVID, which revealed that dexamethasone, for example, was potentially a lifesaver and did in fact save lives rapidly during COVID. We're interviewing new molecules. So what we're doing is we're taking these molecules that have been licensed for other things you might have heard of, trazodone, other drugs, some antihypertensives, and we're going to put these into a clinical trial in parallel with a shared placebo group. We've had an awful lot of PPIE work on this. What are people willing to take? How many times a day are they willing to dose a medication, etc. etc. What this means is we can fail drugs fast. So if it doesn't work, you don't stay on it. And in fact, if it doesn't work, you can go back into another treatment group. So you have a much higher chance of, number one, not being exposed to placebo, but number two, if the drug arm you're in doesn't work, you can go back in and be re-recruited to the study. Given that these are already licensed medications, we've talked to the MHRA about what they need from us at the end of this study in terms of relicensing these medications for use in Alzheimer's disease. And that hopefully will mean rapid translation into new treatments for Alzheimer's for people living with early disease. Next slide, please. So we're not only focused on treatments, although it's a big focus. We also look at hearing. We know that hearing loss is prevalent in people living with Alzheimer's disease and dementia in general. We don't know whether Alzheimer's causes those hearing problems through neurodegeneration, or whether the hearing problems just occur because you're older and that makes your dementia worse because you're socially isolated. But we are doing work with Jenna Littlejohn to take blood biomarkers, which you might have seen on the news this morning, and to measure those against your hearing loss and see if there's a neuroscientific connection between those two things. We also have a sort of NASA-style microscope available, a retinoscope available, which has been developed by one of the physicists in the university. And what this does is it harnesses some of the science around astronomy to adjust lenses
Your eyes are not perfect and they're darting around all the time, and the blood pulsing in the back of your retinas makes it very difficult to take a clear photo. They're often fuzzy. We can now identify single red blood cells in those blood vessels at the back of your eye. We can possibly see amyloid and possibly see other changes that might be an indicator of what's going on in your brain. As you might have seen on the news this morning, we're heavily involved, and I'm a co-investigator on the READOUT study, which was again funded by the Dementia Mission to the tune of £4.5 million over the next 5 years. We're measuring not just early Alzheimer's, but how many people are living with hearing loss. And we're piloting some work with ENT to measure hearing loss using a simple intervention in the clinic. So people will be not only questionnaire screened, but actually screened in terms of pure tone audiometry. We're interested in using virtual reality and working with Nobel Prize winners in UCL, John O'Keefe and others, to use virtual reality to see if people very early on have wayfinding difficulties and difficulties in a virtual environment and finding their way around. But we're also looking at the impact of comorbidities. So chronic kidney disease, COPD, how do these affect the progress of cognitive impairment? Are people with those diseases at higher risk? In combination with industry, we're not keeping the CSF pilot to ourselves. What we're actually doing is rolling that out across the country. So we're working with partners in Sheffield, Sussex, and elsewhere to make this more available. And we've done a lot of work with a local laboratory, which means that people don't need their own -80 freezer. They don't need to faff about with a pipette, and they can just pop stuff in the post to MFT labs and get a result within 2 weeks. And a study that we started before COVID, but became sort of irrelevant, and then we've revamped it. So this is using blood tests, our blood biomarkers, and a little bit of a fancy MRI scan, as well as a simple pen and paper test to see whether that's equivalent and could shorten people's assessment at the earliest stages. So I think I'll stop talking now and maybe ask for some questions, Emma. Thanks.
Yeah, and if you do want to see any of the studies that GMMH is recruiting at, you can go and look on our active studies finder on the research and innovation page. You can filter by dementia or Alzheimer's or even mild cognitive impairment, and you should see any of the studies that are open, and it will tell you who we're recruiting, if we're recruiting, and how you can get in touch. So if you have more questions about that, definitely visit our website. Right, so I will quickly go on to next steps and Q&As. I'm going to skip showing you how to do it again because I've seen some people have already posted some questions and I really do appreciate that. So we'll try and get through the ones that have been asked right now as quickly as possible. We got a few that were submitted just before the webinar as well. So the first question we got is from Jonathan, and he says, are we able to refer to brain health clinics via MAT service? How would patients from outside of Manchester access the brain health clinics, i.e. Salford or Trafford?
Great, thanks, Jonathan. The short answer is email me because we want to work on it. The long answer is yes, you can. I'm happy to see those referrals, we're just at the point where we're sort of ready to scale. Obviously, I haven't cloned myself. I can't multi-locate, so there's a limited number of patients I can see a week. But we do now have, in combination with MFT, we have access to a new advanced nurse practitioner. We've got a nurse, Alex Cook, who's now funded from philanthropic funds over the next year. He's doing Orbans, he's doing LPs. We are just at the tipping point where we're ready to start accepting people from other services. On the other hand, if you've done a pretty thorough assessment and you think somebody might benefit from just having a biomarker test, they don't have to come through my clinic. I'm happy to receive a referral form, which I can send you, and we'll just put a needle in them and get you an answer.
Fantastic. We've also just had a quick question. Will we get a copy of the slides? Yes, we're hoping to send out a follow-up email in a couple of days. It will have a link to this video that we're going to put on YouTube. We're going to give you the slides, and if you've attended, we'll also give you the CPD certificate along with that too. You just have to bear with us for a couple of days so that we can get those together and get them out to you. We have a question from Lindsay saying, can folks safely access newer medications through private health services? Are health insurers involved?
My understanding is they're not reimbursed by Bupa or other similar health providers. They're about £56,000 a year. And that includes the cost of multiple MRIs, neuroradiological input, etc. I have heard a rumor that one of my colleagues, Richard, at the Cleveland Clinic London, is planning this. In GM, I'm not
happy for people to just do this from an office. These are very serious drugs. They need monitoring. They need gatekeeping. People need to be stopped sometimes, depending on the drug. That needs a big MDT, and we've put together that MDT. So we have neurologists, pharmacists, neuroradiologists, stroke physicians, because everybody in the conurbation who's on a stroke service needs to know about these drugs. We've pulled that group together. We've had our first meeting, rather kiboshed by the NICE decision, but we're going to regroup in the next couple of months and start doing some education and start doing some pharmacy work and working with the Greater Manchester Medicines Management Group, because it will be down to the ICB in the end whether these are funded if NICE says go ahead. So I would not want my father, who's been recently diagnosed with mild cognitive impairment, I would not want him to have a brave doctor sitting in an office somewhere prescribing these for him. These need MDT support.
Thank you, Ross. We've got a question from Ella. I think this kind of ties into how people can get more involved in ongoing research. Is it possible for staff from memory clinics to shadow you in your brain health clinic at all?
Yes, thanks for volunteering, Ella. Good to hear from you. The first thing I would say is send us emails, send us NHS numbers. If you've discussed research with your patient, all me and Lewis need is an NHS number to take it forward. We will do the work. We will do the legwork, contact people, fit them into the right study, and we do it in a very sensitive way. Nobody's initially approached about a clinical trial. They'll be approached about an observational study first, giving us a bit of blood, and we'll explain. We do all of that. That's what we're paid to do. The second question is it possible from staff from memory clinics? Yes, and they do. So please get in touch and we'll slot you in. Ideally for a new patient rather than follow-up, so you kind of see the full assessment. So we may not be able to do it like next Tuesday, but equally, people I'm very happy to see people coming and watch lumbar punctures. And if I can get them to faint, it's 100 brownie points. So it's only happened once with a student nurse. Most of the time, people are fine.
We've got Vivian, who said, I currently have several patients with a diagnosis of early onset Alzheimer's who are very interested in research. Can I pass your details to them?
Ideally, not my personal details, but we have a dedicated email address, which is dementiaresearch@gmmh.nhs.uk, where you can send on anything you like and we will follow it up.
Yeah, so dementiaresearch@gmmh.nhs.uk. Lewis and Ross, do check that, it goes through to them. We also have askaboutresearch@gmmh.nhs.uk. If you're not sure, or anything else, you can copy that in as well. So Ella said, thank you, Ross, for your answer. When I said staff, it really meant me. She will be in touch soon.
Very happy to see it. Yeah.
You're recruiting people already.
Well, I mean, I've already stolen Alex Cook from the central team. So if I manage to get Ella out of North and get her funded, well, I'm very happy to.
Fantastic. And yeah, we do really want to build research capacity and ability in our department and across the trust. So if there are questions about how you can get more involved in research generally, or you'd like to know about different pathways of support that you can get, I can connect you with the right people. So please do email askaboutresearch@gmmh.nhs.uk. I'll just have one or two more quick questions, and please just pop off if you need to. Is there any evidence of cognitive changes of people who have had COVID or the COVID vaccination?
Good question. One of the studies we just finished was a Cicero study, which was funded by NIHR. One of my colleagues in UCL, Dennis Chan, ran this across 3 sites. We recruited about 30 people, quite a diverse group of people, under 60, to make sure there was no confounding neurodegenerative disease. And we measured them using both the R-bands, which I mentioned, which is a difficult test, and we did really difficult tests online, things that were dedicated to response speed and very difficult attention tasks. And that's where we found the difference. So that study will be out in the next few months. We hope somewhere relatively impactful. And post-viral fatigue is real. What I can reassure you about, though, without giving away too much, is people recover. They spontaneously recover, And if they've got physical symptoms, those can be rehabilitated. So it's not doom and gloom. There's spontaneous recovery in post-COVID fatigue and in long cognitive COVID, which is what we've called it. We used a telehealth intervention, which was about goal setting, so nothing fancy. And because the statisticians haven't let me yet, I haven't seen the results of that, but I'm kind of quietly confident.
Thanks, Ross. Another question that we've had was, do people want to know their diagnosis at an early stage? What are their reactions?
So this is really interesting. So my colleagues were all telling me, not all my colleagues, but some of them were really skeptical. Oh, they won't want to know, and what are you going to do? And it'll be terrible, and they'll be living with the knowledge for 5 years. And I suppose my riposte before we started the clinic was, well, at least they'll be living with the knowledge. I have great faith in my patients, actually. They're usually really sensible, and they know what they need. They know what they need much better than I know what they need. And so, no, I'm not sticking needles in anybody who doesn't want it, and some people don't want it, but actually it's a tiny minority. So 3 to 4% of people don't want to know, and usually they have slightly more advanced cognitive impairment. Most people afterwards, honestly, when you tell them that it's real and there's an explanation for it, and by the way, we have a research unit that you can to partake in clinical trials, their shoulders drop. They kind of knew something was wrong. They're relieved to have something to call it, and they can start planning. And what we talk to them about after diagnosis is driving, telling your insurer, planning for the future, LPOA, all those kinds of things, making sure that you have a plan. This is the time when we can prevent future crises. So there are difficult conversations to be had within the family, and those may include where you want to live in the immediate term and otherwise. Now they have 5 years to make those plans. Now they have 5 years to go and visit the place they always wanted to. And I have a patient who's driven to South Africa, across Europe and Africa, because it was on his bucket list. He was fine to do that. We'll get him into a clinical trial when he comes back. And people want to know. They have, I believe in autonomy. I believe in giving people choice. I'm not a paternalist. I don't believe that we know what's best for our patients. So if they want to know, I'll tell them, and then they have more choice.
And then we've had a few colleagues talk about their own personal experiences of having loved ones who are going through this process. And one asked me, when should I encourage my partner to go and get an assessment if I'm concerned about their short-term memory or something about their functioning? How long should I wait?
Don't wait. Don't wait. I'm happy to see people who don't have Alzheimer's disease. I'm very happy to tell people there's nothing underlying this, that this is normal aging, that this is maybe depression, which I see quite a bit of. That it's something else. Obstructive sleep apnea, we pick up a lot of. Other things which can affect cognition. Don't wait. There's no benefit to waiting, to my mind. And there's no such thing as worried well. If you're worried, you're not well. Come to me. Let me reassure you. I will do it on the basis of the evidence we gather. And if I can't reassure you, I'll tell you what's wrong.
I'm sure that's going to be really reassuring for some people going through some personal experiences. Thank you, Ross.
Hope so.
So I will just quickly do a little pitch here to remind you of how you can get in touch with us. All of this is also on our research and innovation part of the website on gmmh.nhs.uk. So to get in touch with the research unit, with Lewis and Ross directly, dementia research at gmmh.nhs.uk. I've done a little nice mock-up of what the website looks like so that you can see it's not that scary, and we've tried to make it as interactive as possible. But you can search through all of our recruiting and open studies to see what we're up to see if you can recruit people, to look at the participant information sheets and how to get in touch. So if you'd like to browse that for any number of conditions or issues, you can do that and filter there. We also have our social media channels. At the moment, we're posting a lot about when we have GMMH authors who are publicising their work. So they've got to the end of a study and they're writing about it. We're going to do more on there soon, but give it a follow on X, on Insta, on Facebook, and you'll start seeing some of those publications and where you can go and read them. So hopefully that will also help if you'd like to do a bit more background reading. So thank you all so much for your time. We really appreciate it, and especially to those of you who are still here and stayed for an extra 10 minutes to listen. If you have any more questions, please do get in touch. We're really, really happy to engage with you, and we want to see as many of you as possible getting involved in research. So I'll end it there, and I hope you have a lovely rest of your day and a lovely rest of your week. Thank you very much.
Thanks.